Hi everyone and welcome to our module on cholinergic agonist. In this module, we're talking about the groups of drugs referred to as cholinergic agonist, and we will talk about each of them in relation to the classification, examples, mechanism of action, the indications, adverse effects, contraindications, and clinical significance. Cholinergic agonists are also referred to as cholinomimetic agents. The reason for this is because cholinergic agonists tend to have similar actions to acetylcholine. If you remember from the previous model, acetylcholine is one of the neurotransmitters of the autonomic nervous system. Hence, drugs that tend to mimic its action are drugs that would also be working on the receptors that are peculiar to acetylcholine, which are called cholinergic receptors. These receptors are found on different sides of the body, including the effector organs supplied by the parasympathetic nervous system, sweat glands, which are supplied solely by the sympathetic nervous system, and at the ganglions. So cholinergic agonists can be classified into two major subgroups. We have direct acting drugs. These are drugs that work directly on the receptors. And we have the indirect acting drugs. These are drugs that don't work directly on the receptors, but they tend to increase the amount of acetylcholine present at the synaptic space. And this excess acetylcholine would now act on the cholinergic receptors present there. The indirect acting drugs are also referred to as acetylcholinesterase or anticholinesterases. To further break down this classification, direct acting drugs are further classified into choline esters or alkaloids, and this is based on their chemistry. And then the indirect acting drugs for acetylcholinesterase are broken down further into reversible drugs and irreversible drugs. There's a separate way of also classifying cholinomimetic agents. We could also classify the direct acting drugs based on what particular type of receptors they act on, since they are direct acting. So we could have drugs that are acting purely on muscarinic receptors. These are muscarinic direct acting cholinomimetic agents. And we have drugs that could also act purely on nicotinic receptors. These are nicotinic direct acting cholinomimetic agents. And most of the muscarinic drugs are now further classified as choline esters or alkaloids. For the indirect acting drugs, we could classify them in a separate way. We either classify them as being short acting, intermediate acting, or long acting. Usually, the short acting and intermediate acting tend to be reversible. The long acting tend to be irreversible. And the examples of cholinergic agonists with respect to the different subtypes are very important for you to note for your examinations. Starting with the direct acting drugs, examples of choline esters include drugs like acetylcholine, which typically exists as a natural ligand, carbachol, methacholine, and betanicol. If you pay attention, you notice that each of these drugs tend to have a col somewhere in their name. So you can see acetylcholine has a col somewhere, CHOL. Betanicol ends with a col. Methacholine has a col somewhere in its name, and then betanicol as well has something as a col in the net. For the alkaloids, drugs that are referred to as alkaloids, examples include drugs like muscarine, pilocarpine, ariocholine, oxytremorin, nicotine, and lobelin. And if you also pay attention, you notice that most of these drugs tend to end with the "in" somewhere in their name. So muscarine ends with the INE, same thing with pilocarpine, and then the rest of the other drugs. Now, muscarine is important to note because muscarine tends to particularly be selected to muscarinic receptors, hence the name. Nicotine as well is selected to nicotinic receptors, hence the name. Muscarine is usually gotten from fungi. Um, Nicotine is typically known for its use as an illicit drug in cigarettes. Most of the other drugs are used for clinical conditions, and we'll talk about that when we get to the indications and uses. Other direct acting cholinergic agonists that are not classified as either choline esters or alkaloids include drugs like cevimeline, varenicline, and dimethylphenylpiperazinium. And each of these drugs can also use clinically, but most of the time we tend to use them in research for research purposes. On the screen below, you would notice the drug varenicline. Varenicline um, tends to be prescribed for people that have nicotine addiction. For the indirect acting drugs or the anticholinesterase agents, we classify them into reversible and irreversible drugs. Starting with the reversible drugs can be further broken down into the short acting, intermediate acting, and long acting drugs. Or if we want to talk about their chemistry, we will break them down into simple alcohols, carbamates, and others. Starting with the simple alcohols, the only drug of note under the simple alcohols are is referred to as edrophonium. Edrophonium is short acting. Usually, the duration of action tends to last for about 15 minutes, and it's a drug that is shown directly on the screen here. We'll talk about the uses of edrophonium when we get to the indication and uses aspect of the slide. Chamamates are the second class of reversible or competitive um, anticholinesterase agents. They are intermediate acting, they tend to have a duration of action of about 3 to 6 hours. Examples of drugs under this group include drugs like physiostigmine, neostigmine, and pyridostigmine. The long-acting reversible anticholinesterase, these tend to have a duration of action of 6 to 8 hours. Examples under this group include drugs like ambenonium, donepezil, tacrines, rivastigmine, and galantamine. And these drugs tend to be classified as well based on chemistry as others, although rivastigmine tend to also be classified as a carbamate. So all the irreversible indirect acting or anticholinesterase agents are all long acting, and these drugs are drugs that we don't necessarily use clinically, or they're drugs that we tend to use as insecticides or as wall gases. Typical examples of irreversible anticholinesterase include drugs like organophosphates or different organophosphates like epochlorophate, isoflurate, and methylphonates. These are drugs that are typically used as insecticides in farms. As you can see here, we have other insecticides that are not classified as organophosphates, drugs like marathion, naloxone, parathion, and paroxone. And each of these drugs is important to note the fact that they are irreversible or non-competitive makes them very toxic. We'll talk about some of their adverse effects in terms of toxicity when we get to the adverse effects section of the slide. The final example of irreversible or non-competitive anticholinesterase are war gases. And these are gases that were used during the First World War, and people that made use of this gas had the upper advantage because the gases paralyzed their enemies and they could attack from there. Examples of war gases include gases like sarin gas, suman gas, and carbon gas. And there's a picture down below to show examples of the use of war gases. The mechanism of action of the various cholinergic agonists tend to differ depending on whether we're talking about direct acting or indirect acting agonists. For the direct acting agonists, these are drugs that will bind directly on the receptors. So they could either bind on nicotinic receptors within the ganglion, or they could bind on muscarinic receptors within the visceral tissue. For drugs that tend to bind on nicotinic receptors, the mechanism of action tend to be straightforward. Remember that nicotinic receptors are inotropic receptors. So once the drug binds to these receptors to lead to the opening of ion channels, particularly sodium channels, potassium channels, and there will be an influx of ion, influx of either sodium or potassium, and this will lead to the various changes that we want to see at the site where the receptors are found. So the nicotinic receptors, like I said, are found usually on at the ganglion, whether sympathetic or parasympathetic. So once the drugs bind on these receptors at the ganglion, the postsynaptic neuron would have an influx of sodium within it, and as a result, become depolarized. For muscarinic receptors, drugs that tend to work on muscarinic receptors are drugs that would make use of G protein and the various secondary messengers accompanying with it. Remember that muscarinic receptors are also called metabotropic or G protein coupled receptors. So drugs that tend to bind on these receptors will first of all activate G protein, and after doing so, they'll lead to either a production or a decline in a particular secondary messenger. Remember that muscarinic receptors present within the viscerals are of three major types in the ANS system. We have M1 to M3 receptors. M1 and M3 typically makes use of the GQ G protein, and as a result, activation of these GQ receptors will lead to an increase in secondary messengers of IP3 and DHA, and this will lead to an increase in calcium level and an activation of protein kinase C. The M2 receptors, whereas makes use of the G protein GI. Stimulation of GI will lead to a decrease in the production of cyclic AMP, and this will lead to an inactivation of protein kinase A. For the indirect acting drug or the anticholinesterase, these are drugs that don't work on the receptors directly. They tend to work whereas on the last step of the biosynthesis of acetylcholine, which is on the metabolism step, they act on the enzyme responsible for breaking down acetylcholine. That enzyme is acetylcholinesterase. So they bind on acetylcholinesterase and block the enzyme. In doing so, acetylcholinesterase will not be available to break down acetylcholine. As a result, we have accumulation of acetylcholine within the synaptic space. We have excess acetylcholine present at the synaptic space. And this excess acetylcholine can now do its work at the nicotinic or muscarinic cholinergic receptors present at various sites. And this is a picture that depicts for us the mechanism of action of our direct and indirect acting parasympathetic or parasympathomimetic agents, or we call cholinergic agents. On the right side of the screen, you will notice that we have the direct acting drugs, direct acting cholinergic agents that are going to be working directly on the receptors. As you can see, the drugs are represented as D, and they bind on the receptors and stimulate the receptors, just like what we see with acetylcholine, which is the endogenous ligand. On the left side of the screen, what you would see is the indirect acting drugs and how they tend to work. So indirect acting drugs, you can see them represented with the letter DD. They act on the enzyme breaking down acetylcholine, the anticholinesterase, the acetylcholinesterase enzyme. You can see them binding on this enzyme and removing the enzyme from the synaptic space. As a result, what happens is that you have acetylcholine being in excess at the synaptic space, and this acetylcholine can now work at the receptor site. And this is practically how the indirect acting drugs tend to do their work. What are the indications or uses of cholinergic agonists? Cholingeric Agonist has numerous uses, and some of the uses include things like post-operative ileus. Post-operative ileus is a condition that tends to occur when a patient has gone into surgery, comes out of surgery, and is not able to move their bowel, is having constipation. And common drugs that we tend to use for treating this condition, common cholinergic agonists we use in treating this condition includes drugs like betanicol. Another condition also related to constipation is acute colonic pseudo-obstruction, and in this case, we tend to treat the obstruction of the colon by giving cholinergic agonist. Cholinergic agonists like betanicol that we can use for treating post-operative ileus and acute colonic pseudo-obstruction tend to perform their action on muscarinic receptors, and what they tend to do is that they tend to increase peristaltic action on the GI wall. Other conditions like neurogenic ileus and urinary retention also uh, tend to make use of drugs like betanicol as well. Betanicol will just stimulate muscarinic receptors on the wall of the urinary tract or on the wall of the GIT, and as a result, lead to peristaltic movement and evacuation of each of these different sites. Another condition that we can use cholinergic agonists to treat is glaucoma. I'll talk about this in the next couple of slides. But the typical example of a drug we use to treat glaucoma is pilocarpine alongside carbachol. Other examples of or other indications for use of cholinergic agonists is keratoconjunctivitis, Zika, and Sjogren's disease. These two conditions we tend to see issues with tear production and salivary production. Sjogren's disease is problem with salivary production and tear production. For keratoconjunctivitis, Zika is problems with tears production. As a result, the person might be having dry eye and a dry mouth. Common example of drugs that we can use in treating this is pilocarpine alongside carbachol. These drugs will stimulate muscarinic receptors in the salivary glands and with the tear glands, and thereby increase the production of tears and saliva. Other indications are myasthenia gravis. For myasthenia gravis, it's interesting that we to note that particularly indirect acting drugs like the carbamate and the simple alcohol can be used in both the diagnosis and the treatment of myasthenia gravis. For the diagnosis of myasthenia gravis, we tend to prefer simple alcohols like edrophrenol because of the short duration of action, about 15 minutes. Whereas for the treatment of myasthenia gravis, we prefer to use the intermediate acting drugs like the carbamate. Drugs like physiostigmine, pyridostigmine, and neostigmine are used to treat myasthenia gravis. Then Alzheimer's disease could also be treated using a cholinergic agonist. We prefer to use the long-acting, reversible anticholinesterase agents, drugs like tacrines, like donepezil, like rivastigmine, are drugs that we use in treating Alzheimer's disease. And then finally, anticholinergic overdose. As use of cholinergic antagonists, excess use of cholinergic antagonists could be treated with an antidote of cholinergic agonist. So, if someone has taken a cholinergic antagonist, an overdose of cholinergic antagonist, how we treat is by giving a cholinergic agonist. A particular cholinergic agonist of choice are usually the carbamates, so drugs like neostigmine, phyostigmine, and pteridostigmine are used for treating anticholinergic overdose. So this is the picture of glaucoma. And what tends to happen typically in glaucoma is that there's an increase in the amount of aqueous humor present within the eye. Remember that aqueous humor tends to be produced from the ciliary epithelium somewhere around the eye. And once it is produced in excess, that aqueous humor will lead to increase in the intraocular pressure within the eye. Excess intraocular pressure within the eye would tend to cause compression of the retina and eventually damage to the optic nerve, as you can see here. And this is basically how glaucoma tends to lead to blindness, because once the optic nerve is damaged, blindness will eventually ensue. One way we can treat the problem or the pathogenesis in glaucoma is by giving cholinergic agonists. What cholinergic agonists will do is that cholinergic agonists acting on muscarinic receptors at the ciliary site, at the ciliary muscles, will lead to contraction of the ciliary muscles. Contraction of the ciliary muscles will lead to the flow, increase in flow of aqueous humor, and aqueous humor will be drained from the chamber of the eye towards the area we call the canal of Sclem. Canal of Sclem is usually the site of drainage of the aqueous humor, and with contraction of the ciliary muscles done by the use of cholinergic agonists, more aqueous humor will be drained into this canal, and this will reduce the intraocular pressure and reduce the pressure on the optic nerve and the retina, thereby helping to relieve the symptoms of glaucoma. This is a picture of Sjogren's disease. Remember, Sjogren's disease is an autoimmune condition whereby there's a destruction of the salivary glands and the tear glands, and as a result, there's reduced production of saliva and tears, so there's dry eye and dry mouth as a result. One way to treat this is by giving cholinergic agonists like pilocarpine, which can help in stimulating the salivary glands and the tear glands to produce different secretions. The myasthenia gravis is also an autoimmune condition. The problem in myasthenia gravis is that there's a loss or destruction of cholinergic receptors at the postsynaptic space or postsynaptic membrane. As you see in this particular image, the normal aspect of this picture depicts a nerve and a postsynaptic muscle, and you can see the postsynaptic muscle contain cholinergic receptors present. All right. And as a result, once there's a release of acetylcholine from this neuron, the neurotransmitter can work on the different receptors and lead to muscle contraction, which is what we see at the somatic site. In myasthenia gravis, whereas we see destruction of the acetylcholine receptors present at the muscle site, and as a result, release of acetylcholine will lead to very, very mild muscle contraction, or what we call muscle weakness or paralysis. Myasthenia gravis can be treated with cholinergic agonists, but it's important to note that the main treatment of myasthenia gravis is not cholinergic agonists, but various immune modulators. Because remember, it's an autoimmune condition, and because it's an autoimmune condition, we need immune modulators to suppress the activity of the immune system, which is destroying the cholinergic receptors. So we use drugs like tacrolimus, drugs like corticosteroids as the mainstay treatment of myasthenia gravis. But for treating the symptoms of muscle weakness, we use cholinergic agonists like neostigmine, like physiostigmine, and like pyridostigmine. Then a picture of Alzheimer's disease. In Alzheimer's disease, is a damage to different parts of the brain. Typically, area that gets damaged is the temporal lobe and areas of the brain involved in the limbic system. That's why when someone is having Alzheimer's disease, one of the areas that is affected tends to be the area associated with memory. One of the ways we can treat Alzheimer's is by giving drugs like donepezil, which are indirect acting cholinergic drugs. This will improve the symptoms of Alzheimer's, and thereby they help in retaining the memory lost by the individual. What are the adverse effects of cholinergic agonists? One of the best ways to remember the adverse effect of cholinergic agonists is with the acronym dumbbells. So yeah, just think about a dumbbell, think about different letters of the dumbbell. This mirrors the different letters of the adverse effects of cholinergic agonist. The D there stands for diarrhea. Cholinergic agonist taken in excess can lead to massive diarrhea or GI evacuation. The U there stands for urination. Also, excessive use of cholinergic agonists will lead to urinary evacuation or excessive maturation. The first M there stands for meiosis. Meiosis is the constriction or contraction of pupils, and that is one of the things we tend to see when we use cholinergic agonists. The second M there stands for muscle paralysis. Remember that acetylcholine also tend to act on the somatic nervous system, particularly on NM receptors on the muscles. So the excess use of cholinergic agonists would also lead to these drugs acting at the muscle site, at the skeletal muscle site, and in doing so, they can paralyze the muscles if they are used in excess. And there's a reason for this. We'll talk about that when we talk about the cholinergic antagonist, because there's a tie-in together with the cholinergic antagonist. The first B there is bradycardia. Cholinergic agonists work on M2 receptors found at the heart, and M2 receptors in the heart would be involved in the suppression of heart rate and the suppression of heart rate and the suppression of the force of contraction. So we tend to see bradycardia as a side effect. Then the second B there stands for bronchospasm or bronchoconstriction. This is what we see at the respiratory tract. The respiratory tract on M3 receptors, cholinergic agonists tend to lead to constriction of the airways. The E there stands for emesis. Emesis also means vomiting. Muscarinic receptors are usually found at the vomiting center of the medulla, and stimulation of this vomiting center through muscarinic receptors will lead to the triggering of vomiting. Then the L there stands for lacrimation, which is tear production. As we saw, cholinergic agonists are used in treating Sjögren's disease and keratoconjunctivitis sicca, in which there's reduced production of tears. But excess use of cholinergic agonists can lead to excess stimulation of the tear gland, and that will lead to lacrimation. And then finally, the 2S there stands for sweating and salivation. Cholinergic agonists are going to be acting on cholinergic receptors found on the sweat glands. Remember that sweat glands are supplied solely by the sympathetic nervous system, but sympathetic nervous system at the sweat glands releases acetylcholine, so these sweat glands would have cholinergic receptors. So excess use of cholinergic agonists will lead to excess sweating, and alongside that, cholinergic receptors will also be acting on the salivary glands, which will lead to excess salivation. And this mnemonic is very important to remember in case they're asking you. Just remember dumbbells. Remember the different letters of the dumbbells. Remember there are two M's in the dumbbells, there are two B's in the dumbbells, and there are two S in the dumbbells. And all those letters tend to mirror different side effects of cholinergic agonists. What are the contraindications for cholinergic agonists? Contraindications means different conditions in which we should never prescribe cholinergic agonists for. So one of them is asthma and COPD. Remember that cholinergic agonists can lead to bronchoconstriction, and in asthma and COPD, the patient already has bronchoconstriction, so we don't want to worsen their symptoms by giving them cholinergic agonists, which would cause further bronchoconstriction. Atrial fibrillation could also be a contraindication. The reason is because cholinergic agonist leads to bradycardia. In atrial fibrillation, though the heart is beating very fast, the atrium is beating very fast, but if you give cholinergic agonist to slow down the heart, it could lead to stasis. And one of the things that stasis will lead to is that there will be formation of clots, and these clots can be shipped all the way up to the brain and lead to stroke as a result. So to prevent stroke, we don't prescribe cholinergic agonists to people that have atrial fibrillation. Coronary vascular disease is also a contraindication. Same thing with angle closure glaucoma or closed angle glaucoma. We treat glaucoma, particularly open angle glaucoma, with cholinergic agonists. But for closed angle glaucoma, we prefer to do surgeries because in closed angle glaucoma, the problem is a structural issue, not necessarily a physiological issue. So we tend to use surgery to treat closed angle glaucoma, not drugs. Hyperthyroidism, we avoid giving cholinergic agonists to people that have hyperthyroid. Then intestinal resection or anastomosis, intestinal obstruction. So if there's an actual anatomic obstruction, then we don't give cholinergic agonists because we just need to remove what is causing the obstruction, which is done through surgical means. Same thing with urinary obstruction. So these two, whenever there's an anatomic defect leading to an obstruction, then we do surgeries to remove those to relieve the obstruction, not necessarily giving drugs. And orthostatic hypotension could also be a contraindication because cholinergic agonists tend to worsen the um, situation in cholestatic hypertension by reducing the blood pressure. And as a result, this would eventually tip the person to uh, a life-threatening hypertension. Final thing to talk about in this particular model will be the clinical significance. And there are four areas or four aspects of clinical significance to cholinergic agonists. The first is what we call the Tensilion test. Tensilion test is a diagnostic test for myasthenia gravis. And remember that one of the drugs we use in diagnosing myasthenia gravis is the drug etrofonium. How we tend to do this through using a Tensilion test that we give a patient that has myasthenia gravis that we are suspecting to have myasthenia gravis to give him etrofonium. Once there's a relief of the symptoms, then that would mean that this patient likely has myasthenia gravis because etrofonium is a drug that tends to bind on acetylcholinesterase enzyme and increase the amount of acetylcholine present at the synaptic space. This acetylcholine can now work on the few amount of cholinergic agonists or cholinergic receptors rather present at the muscle site. So what the Tensilion test tends to indicate once it is positive is that there's problems with there's likely a scenario of myasthenia gravis because there's usually a slight relief once we give a patient hydrophonium. Another very important clinical significance is acetylcholinesterase poisoning. So remember that acetylcholinesterase is an irreversible, one of the acetylcholinesterases are irreversible acting acetylcholinesterase like organophosphate. So if someone has taken organophosphate either as a result of exposure in the farm, maybe person is in the farm and a lot of organophosphate was sprayed as insecticide in the farm, or as we typically see, people that are committing suicide might use sniper. Sniper contains organophosphate. Individuals like that have gone through organophosphate poisoning need to be treated. The treatment for organophosphate poisoning is of clinical significance, and the drug of choice for organophosphate poisoning is a cholinergic antagonist. The cholinergic antagonist called atropine. Now note, we use atropine together with another drug called pralidoxime. Pralidoxime together with atropine is going to be crucial in the treatment of organophosphate or anticholinesterase poisoning. The reason for this is because the pralidoxime presence as the extra drug tends to prevent a process we call aging. And remember that the organophosphates are irreversible, though they tend to be reversible up to a point. The process for which organophosphates go from being reversible to irreversible is called aging. And to prevent this irreversibility of organophosphates, we need the drug pyridoxine to reverse that particular step. Atropine is just there to just reverse the side effect of the symptoms, and that's why we use a combination of these two drugs in treating organophosphate poisoning. The last set of clinical significance are what we call cholinergic crisis and myasthenic crisis, and these two things are things that we tend to um, contrast or compare together, and we'll talk about that in the next couple of slides. Now, the difference between a cholinergic crisis and a myasthenic crisis is very important for you to know. For the cholinergic crisis, the problem is that the person has likely taken an overdose of a cholinergic agonist, either an organophosphate or a reversible anticholinesterase. And the symptoms that we see for cholinergic crisis tend to be very similar to symptoms we see for myasthenic crisis. We see abdominal cramps, diarrhea, nausea, vomiting, excess secretion, and meiosis. Myasthenic crisis, on the other hand, myasthenic crisis tend to be a complication of myasthenic gravis. So in myasthenic crisis, what we tend to see is that there is a worsening of the myasthenic gravis in the sense that the receptors present have been further reduced. Remember that the problem in myasthenia gravis is the fact that there's an autoimmune destruction of cholinergic receptors. So for myasthenic crisis, there's further reduction in cholinergic receptors, and as a result, the symptoms are also going to be very worse. So we have symptoms like of respiratory distress, of increased pulse and blood pressure, poor cough, secretion aspiration, dysphagia, and weakness are all symptoms we see. Sometimes the symptoms tend to be similar to cholinergic crisis, and as a result, we have to be able to distinguish them clinically. The best way to distinguish cholinergic crisis from myasthenic crisis is the use of hydrophonium. Remember that hydrophonium is used as part of a Tensilion test in diagnosing myasthenia gravis. So once we give hydrophonium to someone that has myasthenic crisis, there will be an improvement of the condition, so the person will get better. Whereas if we give hydrophonium to someone that has cholinergic crisis, someone that's taking organophosphates, an overdose of organophosphate, the person will have a worsening of the symptoms. And that's how we tend to distinguish between myasthenic crisis and cholinergic crisis. And that concludes our model on cholinergic agonist.